This lecture is about the origin of the dynamic non-resectional mitral valve repair, otherwise known as the American correction. In 1969, Dr. Carpentier revolutionized mitral valve repair by the introduction of his French correction, which involved leaflet resection of the prolapsing segments, followed by a rigid, flat, D-shaped ring to remodel the annulus. Based on autopsy material in 100 subjects, he concluded that the major factor in the mitral regurgitation was prolapsing away of the posterior annulus, and the ring was designed to restore the 4:3 ratio, otherwise known as the magic ratio. Despite 53 years of experience with these techniques, there are still problems worldwide with the classic Carpentier principles and techniques. These include low repairability rates, intraoperative second pump runs, SAM with LVOT obstruction, mitral stenosis, early reoperations for re-repair, poor durability, especially of anterior and bileaflet repairs, and adverse effects on LV flow patterns and energetics. In a report from the Society of Thoracic Surgeons Adult Cardiac Database in 2018, the current overall U.S. valve repair rate was 65%, and for degenerative disease, 82.5%. Systolic anterior motion of the mitral leaflet is still with us, despite excess leaflet resection, sliding plasties, and ring modifications. Number of reports, one of which was only last year from the Mayo Clinic, an incidence of perioperative SAM of 13%. The Carpentier rigid rings are sized to produce the mid-systolic annular area throughout the cardiac cycle, and because this is usually about 30% less than the mitral annular area during diastole, mean gradients of 3 to 4 millimeters are common, and on exercise these translate into gradients of 15 to 20 millimeters. A number of experienced surgeons have noted the need for second cross-clamping after coming off pump, and Dr. Alfieri reported an incidence of 4%, and Dr. Adams 3%. Reoperations after mitral valve repair at Cleveland Clinic documented that 26% of their procedures being done for early failures, that is less than 1 year post-op, and the early causes were suture, annuloplasty, dehiscence, SAM, hemolysis, or ventricular remodeling. 2016, Dr. Suri from Mayo Clinic reported a hazard ratio of 2 to 2.9 for anterior versus bileaflet and bileaflet repair versus posterior repair. Cleveland Clinic 2018 doubled the failure rate for anterior bileaflet repair versus posterior repair. Tyrone David, hazard ratio 3.92 for reoperation after anterior leaflet repair versus posterior leaflet repair. Cedars-Sinai 2022, hazard ratio 3.04 for anterior leaflet failure versus posterior leaflet, with double the failure rate for the bileaflet and anterior leaflet group versus the posterior leaflet group. So the question is, why, after 53 years after its introduction, even skilled and experienced surgeons still experience unpredictable outcomes with the Carpentier techniques despite many modifications? Well, we have to go back to the conceptual foundation of his technique. These are drawings by Dr. Carpentier himself, inspired by the entrance to the Hospital Broussais where he worked, which had 2 large iron gates hinged on a masonry arch. Dr. Carpentier wondered what would happen after an earthquake, and he envisaged that both the doors, the gates would have to be remounted, and there would have to be a remodeling of the surrounding structure, which gave rise to the concept of annuloplasty remodeling. Dr. Carpentier was also influenced by the standard anatomical view of the mitral valve as it was known at those times, which was of an anterior and a posterior leaflet, the anterior leaflet being D-shaped and hinging like doors on the mitral ring, which was where the left atrial muscle attachment transitioned into the leaflets. Anatomists have traditionally viewed this area as consisting of an anterior mitral leaflet attached to a mitral annulus with an aortic mitral continuity, filling in the gap between it and the left coronary sinus, the non-coronary sinus, and the intervalvular triangle. If we look at the area here, we can see the anterior leaflet coming up this zone, which is in direct continuity, which has been called the aortic mitral continuity, but which comes up and attaches to the left coronary and non-coronary sinuses. This area, in fact, consists of one continuous fibrous membrane formed by the fibrosa layer of the anterior mitral leaflet here coming up, now being covered in part by the left atrial muscle, but continuing on up here to fuse with the annulus of the aortic valve leaflets. So you can see here leaflet coming up, and you can see it's in direct fibrous continuity with the anterior mitral leaflet, with the anterior mitral leaflet is in direct fibrous continuity with the aortic valve leaflet. This has given rise to the concept of the aortoventricular membrane, which is that this area is in fact a continuous fibrous membrane, as is in fact seen on histology. So we have a continuity with the aortic valve annulus, the right and left fibrous trigones, the aortic mitral continuity, the intervalvular triangle, and the material continues on into the leaflets themselves as the fibrosa layer of the anterior and posterior mitral leaflets. And this, in fact, is what we see on our 3D echo studies, where we see a large membrane here continuing from the commissural area all the way up to the aortic valve without any intervening obvious differences in structure. The mitral annulus, far from being a flat structure, is in fact highly three-dimensional with a very prominent elevated anterior portion and a somewhat flatter posterior portion with a valley between the commissures. Dr. Gorman demonstrated that there's significant changes between diastole and systole in the configuration of the mitral annulus, characterized by what has been known as steepening of the saddle due to elevation of the anterior portion of the mitral annulus and descent of the intercommissural region into the left ventricle. This motion of the anterior annulus here is determined by its attachment to the aortic valve annulus and the expansion in systole by about 12% of the aortic root, and at the same time the aortic valve and root coming to a more horizontal position. So in diastole and then in systole. So this area here gets kicked upwards and backwards, accounting for this steepening and backward motion of the anterior portion of the mitral annulus. The leaflets themselves have a non-appositional and an appositional area, and the appositional area accounts for about 20 to 30% of the anterior mitral leaflet and about 50% of the posterior mitral leaflet. So 30%, 50%, and these are the areas that actually hinge. The rest of the leaflets really do not hinge off. They certainly do not hinge off the mitral ring. and they don't hinge off their attachment to the mitral annulus, but rather there's an expansion of the leaflet associated with movement of the annulus inwards, bringing the leaflets into apposition. The leaflets for a long time were thought to be inert fibrous structures, but we now know they are complex metabolically active structures and remodel throughout life. They're innervated and have a circulation. The classic description is of the fibrosa on the ventricular side, which is a dense collagenous structure which receives the fibrous chordae. The spongiosa layer, which is predominant in the distal half of the leaflets, and then the atrialis layer, which receives the continuation of the left atrial wall. The anterior leaflet particularly has a somewhat different structure in different areas. In the rough zone here, which is primarily the zone of apposition, extensive caudal insertions associated with collagen blending with the fibrosa of the anterior mitral leaflet leads to this rough thickened area. The spongiosa is at its maximum in this area, and then it thins out more proximally, and we have a region in the middle here which is almost pure collagen, which is almost translucent, and then we get back up into this area where there is some increase in thickness as the fibrosa layer achieves its maximum thickness as it goes up here towards its attachment point. The anterior mitral leaflet has a very important role to play in normal cardiac function because of its high mobility. In systole, it is displaced posteriorly, forming the posterior wall of the left ventricular outflow tract. The left ventricular outflow tract is defined as starting at the free edge of the anterior mitral leaflet and extending up to its attachment to the aortic valve annulus. In diastole, the leaflet moves anteriorly and forms the anterior wall of the left atrial inflow tract. Inflow is directed primarily towards the posterior wall and down into the left ventricular inflow tract. The angle between the aortic annulus and the mitral annulus is critically important for normal cardiac function. And in diastole, this tends to be flattened, making left atrial inflow extend into the anterior wall of the left ventricle. And then in systole, it steepens, bringing the aortic valve over the axis of the left ventricular outflow tract. Now, normal cardiac function, we have realized for many years, depends not just on the presence of the leaflets and chordae, but also on normal left atrial function, the function of the mitral annulus, the mitral valve leaflets, the chordae, the papillary muscles, left ventricular function, and the behavior of the aortic root. These dynamic mitral changes are designed to optimize the development of diastolic locking of the mitral valve and proper zone of coaptation development, optimize leaflet and caudal strain distribution, optimize left ventricular outflow tract dynamics, optimize diastolic LV filling patterns, and prevent SAM. Now, if we look at what happens as systole progresses from isovolumic systole through to peak systole, we find that the leaflet edges have come together in late diastole with a small degree of coaptation, and then as systole progresses, the zone of coaptation increases until it reaches a maximum at peak systole. This is associated with a distribution of stress away from the commissural area and the weak chordae that are generally found in that area to the mitral annulus out here at peak systole. So the proper development of a zone of apposition is essential for minimizing abnormal stress loading of the chordae and the leaflets themselves. If we now put these structures into motion, we can see that the aortic root expands about 12% in systole, and at the same time is rotating to a more horizontal position. This has the effect of moving the anterior portion of the mitral annulus upwards and backwards towards the posterior leaflet and into the left atrium out of the left ventricular outflow tract. So this contributes to enlargement of the left ventricular outflow tract during systole, as well as playing a major role in the positioning of the anterior leaflet in relation to the posterior leaflet. Here we can see on mitral annular tracking, looking anteroposteriorly, the marked steepening of the anterior mitral leaflet in systole, with the commissural areas moving in towards each other. And here, looking at it from above, again, this marked motion of the anterior portion of the mitral annulus upwards and backwards past the vertical here. You can see here it's actually coming up past the vertical during systole. The motion of the anterior leaflet is important to understand because it's not a simple hinging mechanism, as Dr. Carpentier had indicated. If we look here in diastole, we have the somewhat flatter mitral annulus with the anterior portion here somewhat flatter and more horizontal. This line here represents the mean axis of the area of this leaflet plane. You can see here it's somewhat flattened in diastole. Here in systole, the anterior leaflet attachment to the anterior mitral annulus has moved upwards and backwards. You can see this is the movement from anterior to posterior. The mitral leaflet anteriorly, through its attachment to the anterior portion of the mitral annulus, as the saddle steepens, is moved posteriorly, and we now see the development of a more vertical position of the anterior leaflet and the development of the intercommissural valley. And so it's important to note, though, that this line passing through the annulus does not change its angle of joining here. So this is not a hinging motion. This is a displacement upwards and backwards. And it also indicates the increasing convexity of the anterior portion of the mitral leaflet, which is relatively flat over here. Now we actually have some concavity at each side, with the middle portion that's more convex. So the main motion here is upward and backward motion, along with its attachment to the mitral annulus, and an expansion towards the posterior leaflet. And here is the zone of apposition developing as the leaflets come into apposition with each other. Here we can see on this video, this is the anterior leaflet here, the zone of apposition here, and we can see how the anterior leaflet is somewhat concave in diastole, and then in systole it becomes convex, not hinging but becoming convex and being pushed towards the posterior leaflet as the mitral annular motion progresses posteriorly also. And here we can see the anterior mitral leaflet. The aortic root is here expanding and rotating, and this whole area is being pushed backwards here. It's not a hinging motion. And then the posterior leaflet, again, hinging towards the anterior leaflet in the commissural area, but mainly expanding and being displaced posteriorly in the remainder of its portion. We can see here the anterior leaflet being pushed into the posterior leaflet, and the anterior leaflet is also expanding and stretching in this area here, pushing it further into the posterior leaflet here. Here on a 3D echo, we can see the anterior leaflet and the posterior leaflet coming into apposition. And this whole area here, this is the left coronary and non-coronary sinus. This whole area here is being pushed upwards and backwards, causing this very characteristic convexity of the mid portion of the anterior leaflet with some concavity on each side. Note that the anterior leaflet does not open fully back against the septum, but rather only opens about 2/3 of the way open. And then that, combined with the complete opening of the posterior leaflet, helps guide inflow into the left ventricle towards the posterior wall of the left ventricle. Here we can see the effect of the aortic root expansion. On a CAT scan in systole, the aortic root expanded and rotated, pushing in the anterior mitral annulus, displacing it posteriorly, and here in diastole, aorta is relaxed and more vertical, and this area is pulled out to expand mitral inflow. The mitral annulus itself moves down into the ventricle by about 1.4 centimeters, and there is a presystolic reduction in area of about 25%, followed by about another 5 to 10% reduction in area by the sphincteric action of the upper portion of the left ventricle. So the annulus is brought down into the ventricle, and you can see it's significantly smaller here. These movements are in the 1 centimeter range. You can see here the aorta moving upwards and backwards and then outwards and rotating downwards. So upwards, outwards, and then there's expansion here backwards and then downwards. This is how the blood's meant to flow into the left ventricle. We can see here the anterior leaflet directing flow towards the posterior annulus, towards the posterior wall of the left ventricle. And you can see that here it forms a swirling motion known as a vortex, which helps change the direction of blood flow up and out with minimal loss of energy. Here the vortex is shown, the blood's flowing in, and as it drags on the anterior and posterior leaflet, we have this vortex forming that develops and fills up the area between the, in addition to circulating here, it expands in the area between the anterior mitral leaflet and the septum. So here at late diastole, we have this large vortex that's primarily filling most of the ventricle and pushing the anterior leaflet forward and expanding up and out into the left ventricular tract. So in no way, shape, or form is the mitral annulus a D-shaped structure, and in no way is it flat or rigid. Rather, it is exactly as Dr. Gorman described. Now, the aortic mitral angle has an important role to play in the normal function of the mitral valve. As we mentioned, in diastole, it is normally flatter and typically measured in the 120 to 130 degree range. This promotes inflow here into the left ventricle along the posterior wall of the left ventricle, so-called inflow of the left ventricle. And then in systole, it steepens to about 110 degrees. And this rotates the aortic valve down over the, in line with the apex over the left ventricular outflow tract, promoting good ejection. The LVOT is about 2.3 centimeters in diameter and is an oval shape, significantly oval shape. Now, Mitral surgery can affect normal LVOT function by two basic mechanisms. One is a mechanical compression or immobilization of the left ventricular outflow tract. The other is a functional disruption by disruption of normal inflow and outflow patterns. These changes may cause mitral stenosis, SAM, poor leaflet apposition, and eliminating MI may become more difficult, leading to mitral valve replacement. If we look here at a superimposition by computer of a D-shaped ring on a CT of the mitral annulus and left ventricular outflow tract, we can see looking down from above the D-shaped rings being attached in the classical Carpentier manner. And then when we look from the side in the long axis view, we see that the ring has in fact been attached significantly below the aortic annulus and is in fact about a third of the way down the anterior leaflet. And this has the effect of pushing on the posterior wall of the left ventricular outflow tract, which is formed by the anterior leaflet, displacing it forward, and the diameter of this area is smaller than the diameter of this area. So you end up putting a smaller ring in the wrong place, and that has the effect of causing mitral stenosis and obstruction of the left ventricular outflow tract by limiting the ability of this area to move upwards and backwards as we've described. This is further compounded in the Carpentier technique by the fact that Dr. Carpentier, in his book, this is from his atlas, shows the anterior stitches here being placed into the posterior wall of the left ventricular outflow tract and then pulled downwards and onto this rigid, flat ring. So the convexity normally present here is being flattened out and paralyzed by this rigid bar placed across the left ventricular outflow tract. And this has the effect of rotating the aortic mitral angle around to 90 degrees. This has caused enough problems that some have resorted to partial bands to avoid this compression. But in fact, the anterior leaflet goes all the way down to the commissures and the free edge of the posterior wall here. So even rings placed like this are limiting motion here on each side of the central portion of the left ventricular outflow tract. And if there happens to be significant aortic rotation to the right, the right fibrous trigone can in fact end up in this area here. So partial bands may have helped in some patients, but it's not the whole solution. So in 1988, Dr. Carpentier published a study which had been been initiated because he was noticing more and more systolic anterior motion as he operated on more and more myxomatous mitral valve disease. He looked at patients preoperatively and found that the aortic mitral angle was relatively flat. He looked at patients after mitral valve prosthetic replacement and found the aortic mitral angle had changed to 90 degrees, and the prostheses ended up being aligned with flow into directly towards the septum. In addition, with the use of a ring, the posterior mitral annulus was pulled forward underneath the aorta. 90-degree mitral annulus, aortic mitral angle. Now, Dr. Carpentier also noted what he calls superposition of mitral inflow to outflow. And what he was describing was the phenomenon where the maldirected inflow hitting the septum was then had to head down to the apex of the heart and then make its way up the posterior wall and then come across to the left ventricular outflow tract, while at the same time blood was being directed up into the outflow tract from the apex and thus you've got superposition of this outflow and this outflow, and he believed that this outflow going up the posterior wall was responsible for SAM by pushing the posterior leaflet forward. This was based on a study of 20 type 1, 30 type 3, and 100 type 2 mitral repairs. And he saw no SAM in the people with normal sized leaflets, but he saw 14% SAM in people with big leaflets. So he decided to call this excess leaflet tissue, and his solution was to resect the excess leaflet tissue. So in addition to the leaflet resection he normally recommended for correction of chordal abnormalities, he extended the posterior leaflet resection by the introduction of the sliding leaflet technique, which was designed to reduce this excess leaflet tissue. And as many of you know, this was a complex operation that significantly reduced the amount of leaflet present posteriorly and completely and totally flattened and immobilized the posterior leaflet. He continued to use the same rigid ring sized in the same way to the size of the anterior leaflet. So this technique was palliative in the sense that it did reduce the SAM, but it did not change at all the serious disruption of normal mitral valve inflow, because flow continued to be directed towards the septum predominantly. Now, in 2022, Dr. Marici published this very important paper where he used 3D MRI to look at both vortex flow patterns and energy loss. Vortex flow patterns and energy loss in healthy volunteers, people treated with bands, either flexible or semi-rigid or complete rings. What he found was that in all of these repairs, transmitral flow is directed onto the interventricular septum, which we've been talking about a lot, delaying anterior leaflet closure by abnormal vortex formation. His conclusion was it is more important to optimize the flow dynamics after mitral repair with annuloplasty techniques compared with mitral leaflet procedures. We have been very skeptical about the large leaflet theory of SAM, because SAM is not in any way part of the natural history of myxomatous degenerative disease, as shown in 3 Framingham echo studies. The last of these was particularly interesting because they looked in detail at the relative size of the anterior and posterior leaflets and the position of the zone of coaptation. And they've had people with large posterior leaflets and an anterior coaptation, more or less normal distribution size coaptation, and then those with very large anterior leaflets. In none of these groups, and I would emphasize, especially in this group, none of these patients had any incidence of SAM whatsoever. These are all people with myxomatous disease and large leaflets. Our own surgical experience, as we diligently pursued correct sizing, attachment, and maintenance of full annular function, gave us these kind of results. You can see here, Barlow's disease, no leaflet resection whatsoever. And here you can see, despite this huge posterior leaflet here, no left ventricular outflow tract obstruction at all. Now into this already confusing picture, Dr. Perrier injected a further area of uncertainty with the introduction of his respect rather than the resect approach for the repair of the mitral valve. He believed that posterior leaflet resection is not good because it eliminated leaflet area. And so he felt the logical corrective approach was to transform the posterior leaflet into a smooth vertical buttress without resection, and he called this the respect rather than the resect approach. A buttress is a projecting support of stone or brick built against a wall, according to the Oxford English Dictionary, and so it's clear that there was no doubt but that this was designed to immobilize the posterior leaflet in a posterior position in the left ventricular inflow. He used Gore-Tex Cordy to do the respect procedure, but he did everything else exactly as described by Carpentier. So this is really dominantly a Carpentier technique with a minor technical change in terms of the use of Cordy instead of resection. This should not in any way be confused with the American correction, which is designed to preserve normal leaflet and annular motion. This is not the goal of the respect technique. There have been multiple studies comparing the resect and respect techniques with similar results, which is to be expected because they're basically the Carpentier technique in a slightly different form. We agree with recent editorialists who pointed out that it's unlikely that any further studies are going to show any difference, and I would direct them to look elsewhere, as Moriichi has indicated, to preservation of the appropriate mitral annular function, which has been our focus. We support Dr. Moriichi's conclusions fully. So how do we achieve a dynamic repair in a heart that's completely arrested? Well, we have to simulate the critical changes at the beginning of isovolumic systole. And to do this, we first place posterior annular stay stitches, which allow us to pull forward the posterior mitral annulus to simulate the posterior annulus presystolic contraction of about 30%. We look at the valves carefully for the extent of any areas that need caudal support. We mark the desired zones of apposition on the leaflets with dots. We inflate the heart with normal saline at 4 liters a minute, and we inflate it until the left ventricle is fully inflated, the aortic root and the ascending aorta are inflated, the root is expanded, the aorta is rotated. We identify any abnormal leaflet position and correct them with number 5 Gore-Tex Cordy. We check caudal length with repeat inflation to mitral diastolic locking position. We then select a flexible ring size to extend to the aortic annulus above and attach it with running 2-0 Prolene suture. And then we again recheck with inflation. Now, in regard to the mitral valve diastolic locking, this is the mechanism which relates to the sphincteric action of the left atrium. Here's this sphincteric muscle here posteriorly, as dissected out by Dr. Keith in 1907, and here's another dissection from Dr. Anderson in 2007. So this sphincter is a well-defined structure on the atrial, and the mechanism of the mitral valve diastolic locking is that the left ventricle at the time of left atrial contraction is already filled, and that filling has been pretty much symmetrical with the ventricle all stretching out equally. And then the combination of reduction in the annular dimension, the mitral annular dimension, combined with the filling from left atrial systole drives the mitral leaflets together and downwards into the ventricle, and this is all done before the actual onset of a contraction. So this can be simulated by passive inflation. Here you can see the leaflets when the ventricle is not filled up, bulging back up towards us as we add more fluid. And now, as we continue to inflate, we see the leaflet starting to descend in the classic convex anterior mitral leaflet with concavity on each side, and the steepening of the saddle. So this is the mitral locking position. And we know that if the leaflets are properly in alignment at the beginning of systole, late diastole, beginning of systole, nothing will happen other than things get better as the leaflets are pulled together by the annulus getting smaller, the leaflets descending, and the left ventricle getting smaller in size. So this is an excellent and very predictable way of setting up our repairs by using the end of diastole, beginning of systole as the point which we can simulate accurately and then guide us in all our dimensional decisions. We use a laparoscopic suction irrigator. We replace the tip with a flexible plastic tube. They come with a metal tube. And we barely put this through the mitral valve. We'll now show repair of a huge flail anterior leaflet, myxomatous. First step is to place the chordae in the papillary muscles, either on the side of the papillary muscles or between the pre-existing chordae. We bring the chordae up, and each figure of 8 stitch produces 2 chordae, which are separated from each other by a little running stitch through the edge of the leaflet, and this allows us to have enough friction to be able to move the leaflet up and down the chords to adjust them accurately before you make any decision about what the correct dimension is. The leaflets are marked along the anatomical limits of their zone of apposition. The anterior leaflet is typically marked along the rough zone, as can be seen here. Posterior leaflet marked along the 50% transition point, which normally corresponds to the top edge of the clefts. Things are aligned properly. We have our leaflets marked like this, and when they're brought together and they're in proper alignment, both in terms of separation and height, the dots look like that. We use a completely flexible annuloplasty ring, and this is sized to the full dimensions of the mitral valve. We pay no attention to the commissural area, the trigones, the anterior leaflet size. These are sized to the annulus, and by that we're talking about the full extent of the annulus going all the way up to the aortic valve. So this is how things should end up looking, with the anterior part of the mitral annulus being very three-dimensional, arching up, over, and down around the left ventricular outflow tract, so there's no possibility of compression of the left ventricular outflow tract. And here you can see the contrast between the Carpentier approach and our approach. That's going right across the left ventricular outflow tract, preventing it from expanding up towards us. Here in an animal model, we have our finger down the aorta into the left ventricular outflow tract, and we're simulating expansion of the left ventricular outflow tract. And you can see that as we rotate the aorta and the aortic root and the anterior mitral leaflet, this area is restricted from moving back towards us. On the other hand, when we bring the ring up and over and around, as we've recommended, you can see there's no restriction here. There's full, complete aortic root rotation and expansion of the anterior mitral leaflet. Operating room, we have a catheter in the mitral orifice. We're expanding the aortic root and the aorta, which is enlarging here and rotating horizontally. And as you watch, you'll see the upper portion of the anterior mitral annulus, annuloplasty ring, come upwards and backwards towards us, and then the whole valve goes down into the ventricle. Notice the marked three-dimensional aspect of this area of the mitral annulus here. This shows the postoperative result with excellent normal motion of that huge anterior mitral leaflet, no left ventricular outflow tract impingement whatsoever, the chordae, neochordae going down to the papillary muscle. Annuloplasty ring attached to the just below the aortic valve annulus. Here on our post-operative TEE, we can see in the upper part of the picture the expansion of the aortic root with the left coronary and non-coronary sinuses impinging on the anterior superior portion of the mitral annuloplasty ring, which is being lifted upwards and backwards into the left atrium, carrying the anterior leaflet posteriorly into the posterior leaflet. You can see the annuloplasty ring flexing normally with normal annular dynamics. Here we can see a study we performed comparing the Carpentier technique with the American correction, looking at mitral annular area throughout the cardiac cycle from end diastole to late filling. And here we see the physiological reduction in mitral annular area to a minimum at mid-systole, followed by expansion of the mitral annulus throughout diastole and then back down into systole, as opposed to the Carpentier technique, where the mitral annulus here is stuck in the mid-systolic position by design. We carried out studies of our annular morphology from mathematical modeling of our 3D echo tapes. This is the appearance of the normal mitral annulus. This is the typical findings in our preoperative studies of the flattened enlarged ring. And here postoperatively, the contour here was actually indistinguishable from the normal control group. He used cardiac MRI to evaluate the left ventricular outflow tract, and we found that when we compared the pre-surgical dimensions with the post-surgical dimensions in systole and diastole, we found that the aortic mitral angle functioned normally within a good range, and the LVOT dimensions were excellent. In terms of vortex flow, we've done some studies with echocardiography, which is not ideal, and we're now underway with initiating studies with cardiac MRI. But we do have some indications here that we have preserved normal filling of the left ventricle and generation of vortex flow patterns. Here's the inflow from the left atrium directed towards the posterior wall of the left ventricle in this postoperative patient. You can see this vortex forming here, which expands up and behind the anterior mitral leaflet. So if you look at the mitral leaflet here and watch it as it goes in systole towards the posterior leaflet, you can see that's also the time of peak vortex activity in this area. So the vortex here is coming up and expanding, pushing the anterior leaflet posteriorly, and that's associated then with the development of good vortex filling of the outflow tract. Leaflet strain and stress are important in terms of long-term durability. We know from a number of studies that the Carpentier technique produces a very highly stressed loads on the leaflets and chordae, and this is the typical appearance of a flattened annulus with flattened leaflets. This is a three-dimensional annulus with large floppy leaflets. When we look at our own patients, we performed a number of studies looking at strain measurements. And this is the preoperative appearance. This is the postoperative appearance. And here you can see that preoperatively, posterior leaflets, anterior leaflets, and the global strain were elevated preoperatively. Postoperatively, they are markedly reduced. In fact, they were reduced below normal levels. So leaflet strain is reduced, as we pointed out in our earlier series of panels, from beginning of systole through to end of systole. If the leaflets are properly aligned and the annulus can move normally, the strain levels are very minimized in the normally functioning valve. So in terms of clinical experience, of 3,000 mitral surgeries performed, 300 of them were for mitral valve repair. Last year we reported on a consecutive series of 1,068 patients done with no leaflet resections whatsoever between 2021 and between 2001 and 2018. We eliminated second pump runs in hospital reoperation. Was also eliminated. Early reoperation was 14, and this has become almost non-existent now. Late reoperation, 4.7%. Annuloplasty ring dehiscence. When we look at freedom from recurrent mitral regurgitation, 94% at 10 to 15 years. Reoperation, 96%. And prosthesis, 95%. Important to note that all of our patients, anterior leaflet, posterior leaflet, bileaflet, Barlow's, had similar outcomes using these techniques. So we've had no problem with excess anterior leaflet problems. Significant SAM occurred in 0.4% of patients, mitral valve gradient mean 2.2, and again, all leaflets had the same result. So in conclusion, we believe that normal mitral apparatus dynamic function was restored by the use of the American correction with 100% repairability. There was no leaflet resection in 1,068 patients with degenerative disease, no rigid or semi-rigid rings. Dynamic simulation of late diastolic and isovolumic systole of the mitral apparatus facilitates accurate repair and allows highly predictive final testing before unclamping. No second pump runs or in-hospital reoperations. Long-term durability has been excellent and similar for all patients and all patterns of disease. The technique is highly reproducible if performed exactly as described, meaning that this cannot be integrated with some form of Carpentier technique. This is a completely separate and different approach to the problem. A number of surgical movies are available under my name on YouTube, and some other lectures given at Methodist Hospital are also available on YouTube. Thank you.